We have devices such as the oxygen concentrator analyzer, which will measure the amount of oxygen in a mixed gas, which is going into the patient. But the ultimate and most important feedback is the SpO2 pulse oximeter, which measures the actual amount of oxygen that gets into the blood, because that's going to determine whether or not the patient lives and whether or not the patient's brain lives. So this is an extremely critical piece of equipment, diagnostic equipment, and monitoring equipment. And we have already presented a seminar on how to calibrate pulse oximeters. However, we will just do a brief review for those of you who have not been able to attend that prior seminar. We have devices such as the oxygen concentrator. Both fingertip and clinical pulse oximeters use the same process for measuring blood oxygen, and both can be FDA cleared Class 2 devices, but they are not FDA approved Class 3 devices. Both use the same time sequenced channel to measure systolic and diastolic blood absorption of red and infrared light by arterial blood, and then take ratios to get the SpO2, the amount of saturated oxygen saturated hemoglobin. Now, arterial blood has high levels of oxygen saturated hemoglobin that is bringing to the tissues, and venous blood has low depleted levels of oxygen because it is returning to the heart to get reoxygenated in the lungs. The way that the pulse oximeter ignores venous blood and concentrates on arterial blood is by looking for changes in transmission of light, representing systolic and diastolic levels. So venous blood does not pulse, it does not change, it is ignored. It is basically removed by DC or high-pass filtering. Because of the common signal path, the design is ratiometric. And what that means is any variations that happen in channel gain over time affects the ratio of oxygenated hemoglobin to total hemoglobin equally. And so the results are largely unaffected by aging or physics. And that's really important because it says basically once you have a correctly calibrated pulse oximeter, it is unlikely to change its calibration. The primary difference among devices is factory calibration, and in the higher end models, some proprietary algorithms for removing some effects which can affect the accuracy of pulse oximeters. So there is a difference between the inexpensive pulse oximeter, fingertip pulse oximeter you put on your finger, and the high-end hospital ones that cost 100 times more. Once calibrated or miscalibrated, the performance changes little over time. But it turns out that the way in which a pulse oximeter is used is more often associated with the trend performance. So you're looking to see whether or not the oxygen levels are increasing or decreasing to diagnose patient condition. Both fingertip and clinical pulse oximeter readings are used in two major ways by medical staff: diagnostic versus monitoring. So in the case of a respiratory distress response, it's diagnostic. Basically, the staff wants to know just how bad off the patient is from their inability to breathe. And that is basically anything below 85% is serious. Now, if the pulse oximeter is not that accurate, the difference between 60% and 70% isn't going to make a huge difference in terms of the therapy that the decision will be made in terms of how the patient is treated. That is actually the areas where pulse oximeters differ the most, the so-called hypoxic levels or levels of hypoxemia, which is low blood oxygen. Since the goal will always be to get that level above 85%, even fairly inaccurate pulse oximeters can be used in a diagnostic sense, as long as their accuracy is good above 80%. So that is where we're most concerned about the accuracy of pulse oximeters, is in the range of 80% to 100%. Even if they are not terribly accurate, as long as they are repeatable, they can still be used for hypoxia tracking. So trend is the other thing that a medical staff will be looking at. Is the patient getting worse or are they getting better? And ultimately, the accuracy of the pulse oximeter can be verified using a pulse oximeter simulator, but there is difficulty because every algorithm is somewhat different. So creating a pulse oximeter simulator which is reliable, for instance, for both Nellcor, Masimo, it could be very difficult to get accurate readings. Pulse oximeter readings are used in two major ways by medical staff: diagnostic versus monitoring. So here is just a brief overview of how blood hemoglobin gets oxygenated in the lungs, and then it goes out, gets depleted when it delivers its oxygen to the tissue, and it comes back as venous blood, which then must again have the hemoglobin saturated with oxygen. And oxygen saturation is the percentage of hemoglobin that is carrying oxygen in the blood, and you would like that to be 99 to 100%. So here is just a brief overview of how blood hemoglobin gets oxygenated. So here's just a bit of review for you about how two different sources of light, red and infrared, are used to detect the amount of oxygenated hemoglobin in the blood, or that hemoglobin which is not oxygenated. And they have different absorption ratios in those two different wavelengths. And because the same photodiode is being used to detect both, this is what we talked about, the ratiometric design. If there's an error, the error occurs in both sensing modes, and so it cancels out. So that's the basis for determining in arterial blood the amount of the ratio of hemoglobin which has oxygen. So here's just a bit of review for you about how two different sources of light. Here we see a bit more detail of the absorption curves versus wavelength of light for that hemoglobin which is oxygenated, the upper graph, and that which is not deoxygenated, the lower one. As you can see, the absorption is minimal for red light for that red blood that is highly oxygenated, and it is quite high absorption for red light for that blood which is deoxygenated. And you can see at the other end at 950 nanometers, which is the infrared light, you can see that the absorption is higher for the oxygenated hemoglobin than it is for the deoxygenated. So that ratio can be used to determine the mix of hemoglobin that has oxygen and which does not. Here we see a bit more detail of the absorption curves versus wavelength. So how is it that a pulse oximeter can ignore the pigment, the bone, the fingernail, and all the other things in the finger and only look at arterial blood? Well, the reason is arterial blood is the only thing that is changing over time between systolic and diastolic phases of heart pumping. And it is the change that is looked at, which allows pulse oximeters to be mostly blind to changes in things like pigment, finger size, bone, other things. However, there are some studies that indicate indicate that pigment can play a role, and that is a concern in dark-skinned individuals that have hypoxia. Sometimes their reported pulse oximetry is higher blood saturation than they actually have, and that is false positive. That is a very dangerous thing. It's actually a false negative. It's catching the fact that someone has low levels of oxygen. You definitely don't want to miss that. So there has been a paper published that can be a concern in some dark pigmented individuals. So it's not something to be ignored, but it is important to understand that the accuracy does depend on the perfusion index, which is the difference between the systolic reading, and the diastolic. So that can go down in anyone. So for instance, if your fingers are very cold, the amount of blood pumping through the finger is much reduced, and the amplitude of the signal can be very small. And when the amplitude of the systolic versus the diastolic is very small, then the accuracy is going to be very poor. So how is it that a pulse oximeter the plethysmograph is a very important feature of a pulse oximeter, which is actually showing the amplitude difference between systolic and diastolic absorption. And that can be used to determine whether or not the results of saturation are actually accurate. If the amplitude of that waveform is very small, it means a very poor, very small perfusion index. It can mean that very little blood is being pumped through the finger, and it means that you will not be able to trust the saturation reading. So it's important to look not just at saturation, but also at the plethysmograph. And even the fingertip pulse oximeters now will often have a little plethysmograph graph shown below the saturation level. So you can, and some actually have perfusion index number as well, and that will tell you just how big a difference you're looking at in the arterial blood. And certainly one of the biggest problems with pulse oximeters has been low perfusion index means that you don't get accurate or reliable results. And that can sometimes mean having to put the pulse oximeter on a different non-standard part of the body, maybe the earlobe or perhaps a toe, if for some reason, for instance, circulation in the arm is impaired. You wouldn't necessarily get good arterial flow in a finger. So there has to be judgment on the part of the clinician as to whether or not where they place the pulse oximeter is going to accurately reflect the circulation for the whole body. The plethysmograph is troubleshooting a pulse oximeter is pretty straightforward. If there's no signal, usually it's because the light is blocked or reduced in some way that the arterial blood systolic and diastolic levels are indistinguishable. And so it can be confused by certain types of fingernail polish. It may be placed on a part of the body where circulation is constricted for some reason because of an injury, for instance. And then there's the case of erratic signals, which again is poor perfusion. It can be due to motion artifacts if the patient is thrashing around a lot. It can have to do with unstable hemodynamics. So if, for instance, the heartbeat is irregular, which can happen if there's some type of arrhythmia, then also the results will change over time, and particularly the heart rate. The one thing to look at is the heart rate jumping around on the pulse oximeter, and if it is, you can suspect that some type of arrhythmia is going on, which is not unusual in a critical patient. Troubleshooting a pulse oximeter is pretty straightforward. These are FingerSim modules from BC Biomedical Group, and they're designed to simulate artificial human fingers. For 22.5 degrees centigrade, their nominal values are 97%, 90%, and 80%. However, for the more typical temperatures found in Tanzanian labs of, say, 35 degrees centigrade, those have to be derated to levels of 99%, 93%, and 83.5%. So again, they are temperature dependent because of the chemical or fluid that is used inside to simulate. And they can be used without the mechanical modulator, which is very expensive and mates with a non-invasive blood pressure simulator. These cost about $250 US, whereas the entire system costs about $2,500. However, you can purchase these, and if you actually just use your finger to pulse at about 1 per second, you can get most pulse oximeters to respond and give you a saturation value that is fairly repeatable on a given device and from device to device. So this, although it's great to have the entire system, just having these fingers can be an advantage in terms of being able to test particularly hypoxic levels of oxygen saturation. These are FingerSim modules. So just a summary of pulse oximeter calibration using FingerSim. Traditionally, technicians have just tested pulse oximeters on themselves and compared the readings. And the problem with that is it does not test the hypoxic levels of pulse oximeter response, which is really what you want to be able to verify. And so the FingerSim allows testing below 90% saturation, which is really where you need to test. You need to test the accuracy from 80% to 100%. That is where it's most critical for clinical use. And bear in mind that if you use these finger sets, they do depend on temperature. So typically the levels of SpO2 will go up with warmer temperatures in a linear fashion. So just a summary. So this is the accessory that goes with the BC Biomedical non-invasive blood pressure simulator. Basically, it's just a stepper motor which can be rate changed to depress the end of the FingerSim. As I mentioned before, you can do that manually with your finger, and although you won't get an accurate heart rate, you should be able to get pulse oximeter saturation. So this is the accessory that goes with the BC. So here is a BC Biomedical NIBP 1030, which Arusha Technical College has in their biomedical lab, which not only simulates various types of non-invasive blood pressure monitor simulation, but also ECG and pulse oximetry. And these can actually be all coordinated in time. So here is a BC Biomedical summary. Pulse oximeter is a critical feedback of the actual percent of oxygen absorption in the blood based on the percent of oxygenated hemoglobin. It uses absorption of infrared and red light by pulsatile arterial blood to determine the amount of the ratio of oxygenated hemoglobin to total hemoglobin. It is time sequential using photodetector, which actually allows it to be impervious to changes over time. The calibration for hypoxemia, low levels of oxygen saturation, is done empirically by the manufacturer, so it is non-standardized and very difficult to simulate at low levels. FingerSim modules by BC Biomedical give you some ability to check those levels above 80%, and most importantly, at levels of below 90%, which are hypoxic levels. However, once factory calibrated, most professional pulse oximeters do not change much over time. The type of problems we have and faults are poor circulation, most commonly, and intermittent or faulty sensor connections. If you have a main unit with a pulse oximeter probe. Summary: pulse oximeter is a critical feedback of the